Hello class, this is Mia Hartman and today I'll be presenting my capstone project entitled Diet, the Key Ingredient to Preventing, Managing, and Reversing Type 2 Diabetes. My P-code statement for this capstone project is as follows. In adult patients with insulin-dependent type 2 diabetes, with the implementation of a continuous care intervention model with a ketogenic low-carb diet, when compared to the usual care model with insulin administration, impact hemoglobin A1C within 90 days in a primary care clinic in Weeping Water, Nebraska. The primary purpose of this research project is to demonstrate the therapeutic effects of implementing a well-formulated, low-carbohydrate lifestyle program over 3 months in patients with type 2 diabetes. As with any research endeavor, success of the project relies on the ability to recruit invested and actively involved stakeholders. Challenges I would anticipate include the current controversy over high-fat diets and their relationship to cardiovascular health. Large governing bodies, pharmaceutical companies, and health organizations such as the American Heart Association and American Diabetes Association currently support low-fat diets, diet foods, and artificial sugars as recommended for diabetic patients. In the 1970s, there was a growing concern regarding the weight of Americans, and government and public health organizations then pushed for a low-fat diet, and food manufacturers created FDA-approved food substitutes that removed the original fat content as a healthier option. However, these diet, quote unquote, foods did not lead to the results that we'd hoped for. In fact, the rate of obesity has only increased to the epidemic it currently is. Regardless, there has been little to no change in standard recommendations by the corporations that healthcare providers, educational systems, and programs, as well as the general public, hold as truth. Another challenge relates to behavior modification needs from patients, um, as the intervention only works when followed exactly. This requires motivation, sacrifice, initial discomfort from things such as sugar withdrawal, willpower, time investment, reconfiguring, their lifestyle and habits, and adopting new habits. So there's a lot of variables that present this challenge when implementing this program, um, in terms of just the participants themselves. Additionally, organizational funding, patient financial situation, insurance, policy and coverage, patient living situation, environmental considerations, access to resources, facility location, and community government support all present as both influences to the success of the project and as potential challenges and barriers that would be needed to be addressed. This research project utilized the Academic Center for Evidence-Based STAR model, or ACE STAR model. This model was developed by Dr. Kathleen Stevens at the Texas Health Science Center in San Antonio, Texas in 2004. The model serves as a framework that can be used by clinicians seeking to incorporate the best evidence-based research into practice. This model is comprised of 5 key stages, which are knowledge discovery, evidence summary, translation into practice, integration into practice, and finally, evaluation. The A-STAR model is a step-by-step method for resolving the PICO problem. This model will be used to help develop evidence-based guidelines and practices for the use of a therapeutic ketogenic diet for type 2 diabetes management. A-STAR model is also appropriate to guide large-scale changes in clinical recommendations, patient therapy, and healthcare administration. These characteristics contribute to the model's effectiveness. For our methods in statistical analysis, we utilized an open-label, non-randomized control before and after study design with a cohort of patients who self-selected to participate in the ketogenic and continuous care intervention for type 2 diabetes, and a comparison group of patients who self-selected to participate while receiving their usual care from their own medical providers and diabetes education program. Adults diagnosed with type 2 diabetes were recruited via clinical referrals, local advertisement, and word of mouth in Weeping-Water, Nebraska, and surrounding regions. All procedures performed in studies involving human participants were in accordance with the ethical standards of the institutional and/or national research committee. Informed consent was obtained from all individual participants included in the study. Statistical analysis was performed using JMP software. 2 sample t-tests were used to test whether baseline differences and differences between 12-week biomarker changes were significant. Within group changes were tested using paired t-tests, and analysis of the covariance were adjusted for baseline covariates, which included sex, age, baseline BMI, insulin use versus non-insulin use, and African American race. For final analysis, percent change was calculated at the mean difference divided by the mean baseline value. Significant changes in patients' hemoglobin A1C and medication use were tested using McNemar's test. Coming to my absolute favorite part of the Capstone project is the intervention. The intervention was comprised of evidence that was discovered in the initial literature review, meta, and systematic analysis. The intervention is twofold, first being the continuous remote care model, and second being the ketogenic diet. Continuous remote care is a system set to provide intensive, digitally enabled support, including telemedicine access to a medical provider, which in this case was either a physician or a nurse practitioner, health coaching, nutrition and behavior change education, and individualized care plans, biometric feedback, and peer support via an online community. Biomarker tracking tools included a cellular connected body weight, a fingerstick blood glucose and ketone meter, and a blood pressure cuff for those that had hypertension. So each participant was assigned through this continuous remote care model a personal health coach with whom they interacted with initially twice a day at the start of the program. Each patient had a personal physician who monitored their treatment and adjusted their diabetes medicine as their blood sugars improved on the diet. They had a patient support community where they could share their progress and concerns with other patients in the program. Online resources that were easily accessible, videos, podcasts, blog posts, and an individual online chart where their own biomarkers were stored. In this way, the patients were able to quickly review and see how they were doing in real time. So participants were provided with individualized nutrition recommendations that allowed them to achieve and sustain nutritional ketosis. With a beta hydroxybutyrate goal of 0.5 to 3, this was the goal numbers to assess if the patient was within ketosis or not. Patients were also encouraged to report into the application their daily hunger, cravings, energy, mood, and that was used on a 4-point Likert scale. So these ratings, along with the beta hydroxybutyrate or the BHB concentrations, were utilized to adjust the nutritional guidance. So very highly individualized per patient. On the onset of dietary changes, participants were advised to consume a multivitamin, take 1 to 2,000 international units of vitamin D3, up to 1,000 milligrams of omega-3, and if participants exhibited any signs of magnesium depletion, this would look like muscle twitches or cramps. A daily supplement of 500 milligrams of magnesium oxide or 200 milligrams of magnesium chloride was prescribed. Other issues that could come were headaches, constipation, or lightheadedness. Their sodium and fluid intake was changed, were recommended and assessed. Finally, BHB concentrations were also utilized as a marker of adherence to the nutritional ketosis. Behavior change strategies were utilized by the remote care team and tailored to the need of each participant to help achieve glycemic control. At the conclusion of the 12-week program, results showed that participants in the intervention group had an average decrease in hemoglobin A1C of 3.5%. They also had an average weight loss of 12%, which represents about 30 pounds a person. 94% of these participants decreased or eliminated their insulin needs, with 54.7% of the participants reversing their diabetic status completely. In addition, the CCI participants had a improvement in their 10-year ASCVD risk by 12% and successfully decreased or eliminated 22 of the 25 cardiovascular risk factors. If implemented, this study's interventions would drastically change the course of diabetes management. Instead of prescribing additional medications for symptom management, providers would learn to become de-prescribers and collaborate and guide patients to manage, treat, and reverse their type 2 diabetes. Provider education is also a crucial implication, as healthcare providers would need to develop and champion these types of programs for their patients, providing comprehensive education and comparison of diet programs to pharmaceutical treatments and outcomes. Given the potential for the release of financial burden, better quality of life, no daily injections or finger pricks, decrease or no risk of losing limbs, battling non-healing diabetic wounds, all a reality with current treatment standards for diabetes, I firmly believe a vast majority of the populations would gladly follow guidelines proposed by their provider and backed with the supports of the continuous care intervention model to be successful. Further implications of this study give rise to dietary fats, once seen as the enemy of health, now have been shown to prolong life, while the high sugar and carbohydrate diets contribute to illness and disease. There are multiple studies that have concluded and implored that global health and diet guidelines be revisited and reconsidered. This study poses to disrupt the food and nutritional recommendations from many respected sources. The use of the continuous care intervention model, when combined with the ketogenic diet, is an effective treatment for type 2 diabetes. With proper support and patient-provider planning to promote the use of a therapeutic lifestyle intervention, it is possible to successfully manage, halt the progression of, and most excitingly, reverse type 2 diabetes, and at a fraction of the lifetime cost to the patient. We must consider that the financial burden of diabetes management transcends the cost of insulin and medications alone. To obtain an accurate depiction of cost to patients, one must include the cost of the patient's health, the cost of patients, the cost of multiple life-threatening comorbidities, the cost of disabilities, the cost of hospitalizations, cost of decreased quality of life, and sadly, and all too often, the cost of one's life. Radical efforts should be made to educate and implement change within our healthcare system, utilizing evidence-based practices, regardless of potential controversies and challenges that may arise. The outcome of healthcare providers adopting models and interventions such as the ones proposed in this project will give rise to the empowerment of patients. Educated, involved, accountable, and empowered individuals contribute not just to better health for themselves, they contribute to the health of their families and their communities. Those that suffer illnesses that can be managed and/or reversed by these simple measures, regardless of income, socioeconomic status, race, or gender, deserve not just to know this information, they deserve healthcare providers that will champion and support them in these efforts to elevate from a state of disease and illness to a state of health. Well, this concludes my presentation, Diet, the key ingredient to preventing, managing, and reversing type 2 diabetes. I hope that you all enjoyed the presentation and were able to gain new knowledge and information. I always appreciate any feedback, considerations, or suggestions, and I look forward to listening to all of your projects.